Now it's visible. I hope that my PPT is visible for us. Is it?
It's visible. Please make it in a slideshare format.
Yeah, sure. So good afternoon, everyone. So today's topic is I'm dealing with that care of preterm baby and small for gestation babies. So India has a high number of preterm babies, but contributing significantly to globally. That means estimated suggests that around 3.5 million babies are born prematurely in each year, and it is leading to a neonatal mortality. And that's why the India having neonatal mortality rate is very high. And in South Asia, Bangladesh had the highest rate of preterm baby in 2022.
Ma'am, sorry to interrupt.
India, yeah, ma'am.
Slide. It's not in the slideshare view actually.
Ma'am, is it now?
No, madam.
Yes, ma'am.
It's not in the slideshare view.
Now it is.
Stop sharing. Stop sharing. Interval. Share. A by C.
PPT is visible.
No, ma'am, it is blank.
I hope that my PPT is visible for everyone. So preterm baby and small for gestation babies. So India has the high number of preterm babies, and mainly the percentage is in India is 30%. Why it is high number? Because of some reasons are like large population sizes, high number of total births, and weaker health system. If during the care antenatal period itself, we have to give care to the mother. So we have already covered that antenatal care and preparation for the births. So during the time of delivery and during the time of pregnancy, the mother has to get the proper antenatal care, and she should understand how to give care to the child. So mainly the birth weight is the most important marker of the neonate, and from that we will assess the baby is healthy or not. And babies with birth weight is less than 2.5 kg each, we call them low birth weight babies. So in this chart, we can see that the fetal weight growth monitoring. So we have to address the mother while coming for antenatal checkup. In each month, how much the baby has to, the weight should maintain and gain the weight. Month of say fourth month, the baby, the fetus is 140 gram, and in the month of 7 month, the fetus weight should be 13. That means 1.350 kilo, and 8 month it is near to 1.8 kilo, and month in 9 month the baby's weight should be 2.5 kg. And neonate, we can divide in two categories like full-term babies and low birth babies. Full-term baby means the greater than the birth weight is 2.5 kg. The low birth weight baby is less than 2.5 kg. We call them low birth babies. In low birth babies, there are two categories, that means preterm babies and small for gestation babies. So in preterm babies, we can say that what is preterm baby means. Preterm babies are delivered before the completion of the 37th week of gestation. The full term of gestation means we call them in the 14-week gestation, they have to complete. And if they are not, the baby born before that, but before 37 week of gestation, we call them preterm babies. There are subcategories are there. So in late preterm, the baby born between 34 and 36 weeks, and moderately preterm baby born between 32 and 34 weeks, and very preterm babies that born between 28 and 32 weeks, and extremely preterm baby born before 28 weeks. Then small for gestational age baby means the baby is one whose birth weight is below 10% of baby of the same gestational age. That means they will complete their full term. That means they will complete the 40 week of gestation, but they will not attain the proper weight. That means we have seen already that birth weight, the 9 month, they should reach 2.5 kg. But the small for gestation baby, they will not get that the weight compared to the normal baby. So that we call the small for gestational baby. They will complete their full term, but they will not get that exact age. So that we can say that like preterm, that means the weight may be same like preterm babies. So what are the key difference between the small for gestation babies and the preterm babies? The timing of the birth, we call them preterm babies. They born too early, and we call them born too soon babies. While the small for gestational age babies are small because of their gestational age. Underlying causes of preterm babies is they born too early. The main cause, what happened in small for gestation age, that baby is not growing adequately according to the gestation. The complications of preterm babies are organ maturity. And while the small for gestation baby, the main complication is IUGR, intrauterine growth retardation, and intrauterine death, because they are not attaining the proper weight. The main causes of preterm babies and small for gestation babies, like fetal causes, are fetal distress, multiple gestation, and congenital anomalies. That means in fetal, the baby may get the fetal distress like RDS, and multiple gestation. That means a twin pregnancy. Mainly in small for gestation baby, that we can say the main cause is multiple gestation. That means the two babies are not accommodating in the uterus and the weight will be divided into two. So the baby will not get that much weight and congenital anomalies. And in placental dysfunction and placenta previa, abduction placenta, the main causes of preterm or small for gestation babies. Uterine causes like bicornuate uterus. The picture is, you can see that this is a normal uterus and here is a bicornuate. The uterus is like a heart shape divided into two. So that time the baby is not accommodating properly. The baby is not accommodated there, the place. They will not get that much place to live there. So then maternal causes like preeclampsia and high blood pressure, like chronic medical illness, like the mother is during the pregnancy, the mother is taking some medications, or if she's getting some infection, or if she's doing any drug abuse like smoking, or maternal malnutrition are the main causes. And other causes like premature rupture of membrane and polyhydramnios and oligohydramnios. These are the main causes of preterm baby and small for gestation babies. We'll see about the clinical features of preterm. So you know the normal, the how newborn. We have already completed the lectures like newborn care and newborn assessment and everything. So you know about the how the newborn looks. So the preterm clinical features like first the measurement. Their size is very small compared to babies, so that they are having large head and crown hair length is less than 47 centimeters. So the normal weight of the baby, we told that is greater than 2.5 kg, and the height should be, the crown heel length should be 50 centimeter, and the head circumference should be for 35, and the chest circumference should be 33 centimeters. This is the normal. But in preterm baby, we can see that crown heel length is less than 47 centimeter, and head circumference is less than 33 centimeter, and the chest circumference by more than exceeds more than 3 centimeters. And their posture and general activity. We can see that in newborn, how the posture and their general activity, they are very active, and we can see their all reflexes. If we are doing the newborn assessment, we will see the newborn reflexes, all reflexes will be present in term babies. And how the posture of the newborn baby, complete term baby, that means they will keep their extremities like legs and hands should towards to the trunk region, chest region. They will sleep like that. So, but in no preterm babies, they are having incomplete neonatal reflex. Mainly, they are not having motor reflex, sucking and swallowing reflexes. And the lips are extended to hypotonia. That means they are having less muscle tone. Because of that, they are not able to keep their legs and hands towards the chest region, and poor recoil of flexed forearm is extended. And head and face, the head is larger than body. The skull bones are very soft, sutures are widely separated, and frontal are very large. And the face is very small, and small chin and scanty buccal fat. Hairs are scanty and woolly, and you can see the picture, the head and face of the preterm. And eyes are remain closed. You know that newborn babies, preterm babies, after birth, after 2 hours, 3 hours, they will open their eyes and they will look at the face. So that in preterm babies, their eyes are always closed. Eyes are protruding to the shallow orbits, and visualization is very difficult for them. And for ears are very soft, flat, and cartilage is not fully developed. And pinna does not recoil when pressed against back. That means while doing the physical like newborn assessment, we will do the recoil of, we will assess the recoil of the pinna. So that means it will not shrink back to the normal. In preterm baby, the recoil is not present for preterm babies. And skin and subcutaneous tissue is very shiny, thin, and delicate skin we can see, and they're pink color, and they're not having sufficient cornea gaseosa. And subcutaneous fat is scanty, and edema maybe can present, or maybe we can see in preterm babies. And subcutaneous fat is deficient, and you can see the preterm babies and nodules. Breast nodules are small or absent. Preterm baby, they are having sufficient subcutaneous fat, so it's visible, no breast nodules. But in preterm baby, it is not visible in preterm babies. And same like the deep swell cases are also preterm babies are not visible, and full-term babies it is very visible for. Abdomen is very, we can see the baby's preterm baby's abdomen is full, soft, and the veins are visible by doing the physical examination. If you will see the preterm baby, the veins, and we can see the ribs also. We can touch the ribs and we can visibly see the veins and everything for the preterm babies. And genitals in males, testes are undescended and scrotum poorly pigmented with a few rugae means, the normal pure babies, the scrotum, they have sufficient folding is there in the scrotum. Abdomen. So in male, testes are undescended testis and scrotum poorly pigmented with the few rugae. Then it's the the normal rugae is present in normal newborns. That is foldings we can see in the scrotum, but in preterm baby we are not able to see that rugae. The female in labia minora does not cover the labia minora, and clitoris is hypertrophied or prominent. You can see the pigmented or hypertrophied um, clitoris. These are the clinical features we have seen preterm baby and small for gestations babies. So now we will go to the physiological handicaps. What are the physiological handicaps here? Physiological handicaps like respiratory, all the system, they have the problems like respiratory system, respiratory distress syndrome, bronchopulmonary dysplasia, pneumothorax, pneumonia. In cardiovascular system, they have PDA, hypertension, bradycardia. In gastrointestinal system, they have poor gestational function, necrotizing enterocolitis. That means they are not able to, already mentioned that they are not having the sucking reflex. So they may have the poor gestational growth. Because of that, they are not able to suck and they are not able to metabolize the milks and everything. And central nervous system, they're having intraventricular hemorrhage, seizures, deafness, hypertonia. In renal system, hyperkalemia, renal glycosuria, and other problems like hypothermia, nutrition deficiency, increased susceptibility to get the infection because they are not having that much immunity. So these are the main physiological handicaps we can see in preterm babies. But at the common problems of small for gestational age babies like IOD, I have already mentioned that is intrauterine death. That means if they are not able to grow properly, so there is a growth retardation, it leads to death. And they may have birth asphyxia, hypoglycemia, hypokalemia, hypothermia, congenital malformations, infection, polycythemia, poor growth potential. These are the main problems of small for gestational babies. So why? So now we come to the point that is care of preterm babies. Care of preterm babies. Why do premature newborns need special care? So we have already seen the clinical features and the physiological handicaps. They need more efficient care from as a nurse. We have to care and we have to educate the parents. They have also give the proper care to the preterm babies. So premature newborn is fully not, they are not deal with the environment. So we have to give the proper care to the child, preterm baby. The main management means, have already mentioned, we have seen that different subcategories of preterm. So If the baby born at 24 weeks, directly we will send them to the NICU for the gestation and other case. The remaining preterm baby, how we will give the care to the baby from our birth to the discharge. So we will see one by one. The optimum management, first management is at birth. The first management is DCC. What is DCC? That means delayed clamping of cord. Delayed clamping of cord means soon after the birth, normal delivery, the soon after the birth, we used to cut the clamp the cord. We will cut or clamp the cord. But in preterm baby, one we have to do it for the 60 second, we can hold that clamping of cord because why means the clamping of the from the birth, the placenta, from the placenta, the baby will get the blood to the fetus. That for preterm baby, so it will very help to prevent infection of the preterm baby. So that's why we have to hold 60 seconds delayed clamp of cord. And next is elective incubation of extremely low birth baby, that is less than 1000 gram. The baby has to do directly. We have to send them to the NICU and incubate the baby. And next step is probably we have to dry the baby and effectively covered and warm the baby. We have to provide the warmness to the baby, preterm baby. And vitamin K injection, that is less than the 1.5 kg baby. We have to give 0.5 mg vitamin K in intramuscularly. And next, if the baby starts soon after breathing, we can transfer the baby to NICU. Next is what are the things we have to monitor? The vitals, as we have to give, we have to always monitor the vital signs of the baby. And vital signs of the baby and activity and behavior of the baby we have to monitor. And color of the baby, the color we can check that the baby is pink color, yellow color or blue color, and we have to check. And tissue perfusion, how we will check the tissue perfusion? You can check the, you have to monitor the input output chart, the heart rate of the baby. That can see the tissue, check the tissue perfusion. And fluid, how much ml fluid we have to give, and electrolytes and ABG also we have to monitor. And tolerance of feeds also we have to monitor. How we have to monitor? Once we feed the baby, after 2 hours, we can aspirate the fluids from the abdomen. That means we can check what how much remaining milk is there in the abdomen. So that we have to check the tolerance of the feeds. The baby is tolerating the feed or not. If it is remaining more, then we can understand the baby is not tolerating the feed. It is not, it is less remaining if we are while aspirating. If we are getting less and more, that means we can see that the baby is tolerating the feed, and we have to watch for developing of RDS. That is, the baby get respiratory distress syndrome and attack or sepsis, PDA. We have to watch thoroughly for these are the symptoms, and always we have to check the baby's weight. We have to measure the weight should always check. Next is temperature. Thermal, how we will give the thermal care to the baby. Warm environment to give to the baby. That means environment should be always warm. That means the we already mentioned that after soon after birth, we have to cover the baby with woolen clothes. So, and we can provide warm environment like radiant warmer. I can keep the baby in radiant warmer. And main preterm baby care is skin to skin contact, that is KMC, kangaroo mother KMC. We have already completed that lecture, that is KMC. How to give KMC and what are the benefits of KMC. So, skin to skin contact is very important for the preterm baby to attain their weight and to tolerate their the new environment. And drying and wrapping, and we can give hat to the baby and delayed bath. So until discharge that we have to delayed bath. Can tell the parents or family members cannot give bath to the baby because the baby is very small and the skins and everything is, we have seen already the clinical features, how the baby is clinical skin and everything. So we have to delay the bath. And positioning, we can give the positioning to cover the baby and spread position. And while handling the baby, we have to see the 5 clean things. That means clean hand. While handling the baby, our hand always should clean the clean cord and clean cord clamp and clean surface and clean procedure. Next is special measures. What are the special measures we can have to give to the preterm babies? First is oxygen therapy, then surfactant therapy, phototherapy, and neonatal resuscitation. In the oxygen therapy, mainly oxygen prongs, nasal cannula, and oxygen hood we use for the preterm babies. And because we know that the baby are not getting sufficient oxygen, so the weight is less than 1000 or 1.5 kg, we have to always give the oxygen therapy to the baby. So mainly we will use nasal prongs or oxygen food. And next is one important therapy is surfactant therapy. Surfactant therapy means the surfactant we will directly inject to the lungs in preterm baby via endotracheal tube to reduce the surface tension of fluid that then the alveoli. That means the baby's lung is not mature. The baby is not having that much maturity of the lung. So if we are administering the surfactant, the baby will get the maturity of the lung. This one, the baby is able to expand the lung and the baby is able to take them breathe. So that is the surfactant therapy. We will administer directly to the lungs through endotracheal tube. Next is neonatal resuscitation. Why we have to give neonatal resuscitation mainly in the preterm baby? The baby is term in preterm baby, we can say that the baby is not in full term. If the baby is cry or breathe, we can say the preterm baby that if the baby is less than 1000 gram or 1.5 kg, the baby won't cry or the baby is not able to take them breathe. And the baby have a good muscle tone. We have already seen that the baby is having hypotone. And if the answer is no, so we have to resuscitate the baby. Mainly the TABC resuscitation, that is temperature, airway, breathing, and circulation. This is an important uh, resuscitation method we are using for the preterm baby. Then in temperature, first we have to dry the baby quickly and remove the bed linen and place the baby in radiant warmer and the mother care. So that we can give proper temperature, we can maintain the temperature to the preterm baby and airway proper position to the baby and suddenly quickly we have to do the section to remove the secretion from nose and mouth. Normally, there's newborn baby care after birth. We will do the section. It's the same like the preterm baby. We have to remove the secretions from the mouth and nose, and then we can go for endotracheal intubation if the baby is not having proper breathing. Airway to clear the airway. Breathing is stimulate the baby to the breathe by drying and gentle rubbing and tactile stimulation to initiate the respiration. That means if we are doing the tactile stimulation, the baby will get automatically the baby is able to respirate. So gentle rubbing on the backside on the feet to do the gentle rubbing and it will stimulate the breathe automatically. It will initiate the breathe the preterm baby. And next is positive pressure ventilation. We can use by bag or mask and need to do when necessary. When the baby is breathing, we no need to intubate. That means the baby is 2 kg or 1.8 kg. No need to intubate, but according to the condition, we have to intubate the baby. And for the circulation, chest compression we can give in for high risk baby. And then is below heart rate, 60 heart rate. That means you have to give the chest compression and 30 ppb in 1 minute. And medication we can give like adrenaline and dopamine for the circulation and assess the heart rate and color of the baby. This is the TABC resuscitation for preterm babies. Next is phototherapy. Phototherapy means we told that we have to assess the color of the baby. If the color of the baby is yellow, that means we can say that the baby is having jaundice. For the main management of jaundice is what the phototherapy. So according to the gestational week, the baby has to initiate the phototherapy and we have to exchange transfusion. Okay. So and the baby is 34 and 36 week of gestation means if the total bilirubin level is 12 to 14, we have to initiate the phototherapy. And we can give the total bilirubin 17-19, it can give the exchange transfusion. See, the normal bilirubin, we know that it till 0, 1 to the 12. If the baby is, if in extreme preterm baby, that means less than 28 weeks, the baby is having 5 to 6 G per TL bilirubin, then also we have to initiate the phototherapy and exchange transfusion should be 11 to 15 G per TL total bilirubin level. Next is feeding and nutrition. So in mainly the feeding and nutrition, the baby is not able to suck, the baby is not having sucking reflex, swallowing reflex, or more. So the main feeding and nutrition, how when to initiate the fluid and when to give the garbage feeding, when to start the breastfeeding, it's according to the dates of the baby and week of the baby after delivery. So initially the baby is less than 12 gram, or if the baby is less than 30 weeks, maybe we have to directly we will be administer the IV fluids, and just we try the garbage feeding. If the baby is well and if the baby is coping in the feeding, if the baby is tolerating the feeding, we can give the garbage feeding. Otherwise, we have to only give the IV fluid. The baby after 1 to 3 days, the baby after less than 30 weeks baby, after 1 to 3 days, we can start garbage feeding, and 2 to 4 weeks we can start katuri feeding and spoon feeding, and 4 to 6 months once the baby start the sucking reflex, we can tell the mother to breastfeed the baby immediately. Same like that, if the baby is 1.8 kg or the baby born between 30 to 34 weeks, baby, we will start garbage feeding, that is NG2 feeding directly. We will start with that. After 1 to 3 weeks, we can give the katuri feeding or spoon feeding. That means we have to tell the mother to express the milk, and we are not giving any artificial milks. We have to give only the breast milk. That means we have to tell the mother to express the milk, and we can give the feeding through katuri or spoon feeding. Then after 2 to 3 weeks, we will tell the mother to initiate the breastfeeding, and 4 weeks onwards continuously the baby has to take the breastfeeding. The baby is 1.8 gram and above. Directly we can tell the baby mother to start the breastfeeding. If the baby is not having that much sucking reflex, we'll give by katuri or spoon feeding. Then after 1 to 3 days, we'll give breastfeeding, and continuously we'll tell the mother to give breastfeeding to the babies. Then the fluid requirements of preterm baby. So the fluid requirement for the term baby is 60 to 75 ml per kg on the day 1, and increase 1 to 120 ml kg by 2 to 3 days. And preterm baby, we need to start the IV fluids. We have already mentioned that is 70 to 8 ml per kg on the day, and gradually we can increase the baby is 152 ml per kg day. The main complications is while giving the fluid, IV fluids, we should monitor. I have already mentioned that we have to check the weight of the baby, and we have to monitor the weight of the baby. If we are checking, if once we check the weight of the baby, if you are getting sudden weight gain, if you are monitoring, or if you are seeing that the baby is having sudden weight gain greater than 30 gram in 24 hours, that we should check for the baby may have overhydration. That means the baby, that's why we told the monitoring means input output chart we have to monitor, the weight of the baby we should monitor, the hypothermia, the temperature always monitor. So that means if the baby, we are administering the IV fluids, so that time we have to always monitor the input output chart. That means the baby is tolerating the that IV fluid. That means maybe we will see the sudden weight gain of the baby. That means the baby may have, the baby is not having that much output, so the fluid will accumulate in the body, and may chance the baby get edema. That edema leads to the weight gain. Gain weight of the, while checking the, we see the extra weight. So sudden changes in the weight, that always you should focus, and we should check that. And prevention of nosocomial infection. We told that in the newborn baby will, extreme preterm baby will near to 2 months, they will be in the NICU. So according to the week-wise gestation of the age of the baby, we will keep the baby in NICU. So how to prevent the nosocomial infection? The baby will get more infection from the hospital itself. So we have to prevent that, man. How we will prevent? Minimal handling of the baby, and restrict the visitor, and caregiver with nasopharyngeal infections are not allowed. That means if the mother is having any nasopharyngeal infection, if she is having cold or cough, means we will not allow the mother. And how we will, so may think that how we will the feed that we can give by care, Katuri feeding and strict handling of washing. If as a nurse also, we have to wear the sterile gown and strict hand washing. We have to address the mother also. Regular disinfection of NICU, isolation of infected baby, and maintenance of asepsis. Ensure the early exclusive breastfeeding and avoid prelactal feed, and maintain hygiene in katori for spoon for feeding. That means always wash the spoon and katori before giving feed to the baby. And we are not allow the mother give any use dropper or bottle or nipple or any cotton. It's to while giving the feed. They only use the cutlery or spoon feeding, that they have to clean and they have to do the sterilization. And care of umbilical cord may get the infection through the umbilical cord, and prophylactic antibiotic therapy also we can give, can start. So those are the main prevention control we have to do in the hospital. Can prevent the nosocomial infection of preterm babies and small gestation babies. And main thing as a nurse, we have to give the family support to the parents and the family. That means the prolonged stay in ICU. That means the mother may be the first baby of the mother, so she may get emotional trauma to the parents. Same like father and mother. So we have to give counseling to the parents and involve the family, baby care. While giving the care, we have to involve the family members. Why? Once they discharge from the hospital, they should understood, they should know how to take care of the preterm baby, how much care you have to give the preterm baby, how we given the hospital, give the care to the baby in the hospital, same like they have to follow in the home. So that is so that we have to involve the family to the baby care. The main thing is KMC, Kangaroo mother care. So base we have to tell the mother to follow the KMC, the kangaroo mother care. She can keep the baby in between the chest. So it will prevent the hypothermia. And feeding and nutrition, one more thing I want to mention that here we can non-nutritive sucking method. That means while keeping the baby in KMC, the baby may, if you are keeping the baby in chest between, non-nutritive sucking may happen. That means the baby will suck the mother body or mother chest, or we can give clean hand or clean cloud can to the baby's mouth. That means we will help the baby to get sucking reflex. So that non-nutritive sucking will help the baby to attain the sucking reflex. Same like if you're keeping the baby in a, we are telling the mother to keep the baby in a chest, and maybe baby will start to suck. That means that we have to help. We have to initiate. So we have to tell the mother to follow that, and we have to tell the mother to keep clean hands. Always focus that a clean hand to keep in the baby's mouth to initiate the non-sticky sucking reflex. And discharge and follow. In discharge and follow, evaluate for any complaint while doing the discharge and follow. What are the things we have to see? Evaluate for any complications of prematurity, and we have to see the baby is able to breastfeed, can take the breastfeed. The breastfeeding well established or not, that we have to see. We have to check the nutritious supplements like including multivitamins like iron, calcium, vitamin D are started. And immunization, we have to tell the mother to give immunization to the baby's immunization. It will prevent the infection like BCG, hepatitis B, and oral polio vaccines at birth. And mothers are instructed to regarding the routine care of babies such as prevention of hypothermia like KMC, and prevention of infection and proper feeding and maintenance of personal hygiene and growth monitoring, and everything we have to instruct the family members, especially to the mother. And along with that, we have to say some to the danger signs. So we have to tell the parents and family members some danger signs you can see. That means the baby may get feeding difficulty. So don't expect from the day, the discharge the day itself. We have to tell the family members, don't expect that from baby the day discharge on the day, for the baby may feed properly. So it will take few it will take like time. So tell them to adjust that situation, feeding difficulty, maybe baby get lethargy or hypothermia and tachypnea, and just enjoy this. If their baby is having like this problems, tell the mother to inform the baby's pediatrician or to the hospital. And if that just improving means maybe the maybe say signs of that RDA, that the chest enrollment, the chest will go inside while taking a breath, and child may get convulsion if they get getting like this. If you are seeing like any feeding difficulty, and if they are seeing any lethargy of the baby is having any hypothermia, tachypnea, just improving convulsion, tell the mother family members to inform their pediatrician or they can come to the hospital. And once follow up, ensure that baby has to, we have to, once the discharge on the baby has to reach the home, and tell the parents to inform the pediatrician the baby is adjusting the home. So that's the discharge and follow plan. And how, so we have seen now the how to give care to the preterm and what are the physiological changes and everything. So what are the strategy to prevent the preterm babies? How to reduce the preterm babies? So we have seen that India is having 3.5 million preterm babies in each year. Yearly, we are seeing the high number of preterm babies. So how, what education we can give to the people, that means mainly the education to the antenatal mother. One, they are giving to the clinical for the checkup. They tell the mother to do the proper antenatal checkup and medication and everything, and can instruct them to avoid early marriage and health checkup during the time of pregnancy, that is nutrition, and we can give guidance and counseling to the parents and during pregnancy and family planning. And that means if the baby is soon after the first baby, if there is no gap between the first baby and second baby, can you unmute some voices again? Can you unmute that? So family planning, we have to advise the parents about the family planning and antenatal care like balanced diet, supplements and vaccines. And we can advise the mother to avoid chemical exposure like tobacco, smoking and alcohol. And we can tell the mother if the mother is having incompetence of service, that means a one cause of preterm baby. That means the mother is not able to hold the baby in the uterus. That means the mother's cervix will be muscle is very this the baby is not, the mother is not able to hold that baby. It's like incompetency of the cervix. So like that, if management is like we can do the suturing and everything, that also we have to explain to the mother once they are coming for the antenatal checkup. And this is the baby, a preterm baby, that is a baby born on last February 9th. He's admitted in NMMC hospital. So the weight is 8 gram. So now the baby is very tolerating for everything. I'm just I want to show the picture of the baby, see the features and everything. And so thank you. So that's all about the care of preterm baby and how to reduce the preterm babies and we have seen. So I hope that everyone understood that this one, and thank you. So I'm requesting everyone to on your video.
Requesting everyone to unmute your video. We can have a photo, common photo. Thank you, Priyanka ma'am, for your wonderful session. Please keep your video on. for a photo. Please keep your video on for a photo. Thank you. Now I request Tejal Gaikwad, first year MSc Nursing student, Bharati Vidyapeeth College of Nursing, Navi Mumbai, to present her case.
Good afternoon, ma'am. Good afternoon, ma'am. Myself, Prophecy. So today I'm going to share a case. Baby of X preterm 3.7 weeks just age with weight 4 years old GM1 is on 2025 via LSCS, and mother was GDM RH negative peaking PV. Baby name baby of X age today date of admission 2025. Chief complaints coastal retraction difficulty, grunting, and was seen, and baby has low birth respiratory distress. No any past history, no entry. All the prenatal checks were done. Mother has taken all TT vaccination. She was on iron folic acid supplement throughout her pregnancy. Mother is having complications such as gestational diabetes mellitus and leaking PV. And mother is Rh negative, blood group AB negative. Anti-D was given on 13 Jan 2025. On physical examination, vital signs were monitored. Temperature was 36.5 degrees Celsius as baby was prone to hypothermia, and heart rate was 154 beats per minute. Respiration 70 breaths per minute as baby was found technique. On general appearance, traction was was 7 per minute. Man was which is a moderate respiratory distress. On evaluation, chest X-ray was clear. On the echo, where for matters with no analysis, 7 case to 36, 3 was 20 per liter, and every started to injured. Then put calcium 4.8 mg, hemoglobin 3 gram, WBN 500 cells per RBC per platelet 1.8 per cubic millimeter. Anthropometric measurement: height 37 centimeter, weight 1.206 kg, head circumference 27.5 centimeter, and chest circumference 24 centimeter, abdominal girth 23 centimeter. Skin color was in respiratory system. Tachypnic respiratory rate is 7 per minute. Grunting was seen, and silver medicine score was 4. Wisdom S1, S2, no abnormal sound, heart rate was beats for abnormality found. And once the child got stable, child was shifted to NICU for further management, which includes continual mechanical support on SIMV mode. FiO2 was 21%, PIP was 6, and rate was 40 breaths per minute. Prevention of hypothermia by keeping child in radiant warmer. HGT monitoring every 6 hourly. APG monitoring 8 hourly and maintaining acid-base balance. Surfactant therapy injection Curosef 2.5 ml per kg initial dose was given. Antibiotic therapy injection amoxicillin 50 mg per kg BD dose was given. Nutritional supplement injection amnoven 18 ml, that is 1.5 per kg per day was given. Other drugs such as injection caffeine, as one episode of apnea was seen. So 24 mg plus 10 cc D5 over 1 hour was given. On nursing care plan, diagnosis was made effective thermoregulation, hypothermia related to environmental change as evidenced by baby's body temperature, less than normal. Early detection of hypotension like respiratory distress syndrome. Monitor for cold stress, keep the newborn dry and wrap the baby heat. Provide heat loss barriers such as baby was kept under radiant warmer, prevent heat loss, and assess the environment and the warm comfortable environment, maintaining temperature or maintaining body temperature. Evaluation after diagnostic care, baby water increase to normal. Second, ineffective tissue perfusion related to impaired transport of oxygen across alveoli as evidenced by subcostal retraction. Then follow-up and prognosis, monitor oxygen level and providing supplemental oxygen if necessary, treating any underlying infection with antibiotics, maintaining normal body temperature with warm cloths. Prognosis in most cases, baby with low birth weight who has a good prognosis. In this case, baby's oxygen level improved in 48 hours and breathing pattern also stabilized. On day 4, baby to mother from NICU, and on day 5, baby got discharged. Challenge faced in was management. Health education was given regarding breathing and respiratory care. Observe your baby breathing pattern. Watch for sign of difficulty such as rapid breathing, grunting, flaring nostrils, or chest retraction. Health education regarding feeding and nutrition. Breastfeeding is highly encouraged as it is help strengthen immunity and improve recovery. Temperature and environment should be seen. Maintain a warm body and comfortable room temperature. Avoid overheating. Medication, provide all prescribed medication, administer in given dose, route, and frequency as ordered. Follow up, ensure regular pediatric checkup to monitor lung function and overall growth. Any additional testing is recommended. And vaccination should be given as scheduled to protect against infection.
Tejal. Dear participants, kindly fill the feedback form. The post-test link will be shared soon. Please complete that too. Monday also we have a validatory session, so I request all the participants to join for Monday's half-an-hour session. It's just a validatory sessions, and you will be having a feedback form as well. So in final feedback form, you will be receiving your certificate via your mail. Please complete today's feedback form plus the posters link. Posters link is shared in chat box as well as your WhatsApp group. Monday will be the last session. It is for half an hour. Please, I request everyone to join on Monday. That is on 24th March, 2 p.m. So please complete today's post test and feedback form.